Great. Well, it's 12:02, and I think we could probably start. So welcome everybody again. This is the Transforming Maternal Health call with partners from around the state, and I'm going to turn it to Amy Belisle to kick us off.
Good afternoon, everyone. I'm Amy Belisle. I'm a pediatrician. I'm the Child Health Officer at the Department of Health and Human Services in the Commissioner's Office. So we have asked interested parties to join us as we review the notice of funding announcement for U.S. Department of Health and Human Services Center for Medicare and Medicaid Services, Medicaid Innovation Transforming Maternal Health Model Notice, which we might refer to as TMaH on today's call. That was posted on June 26th. The letter of intent is due August 8th, and the application is due September 20th. Before the MaineCare team gets started, I just want to provide just some brief background of some of the work that's been happening in the state on building a stronger perinatal system of care in the state. There's been a lot of work over the past 5 years as we try to achieve a common vision and goal of achieving the healthiest possible pregnancies and the best maternal and birth outcomes in all areas of the state and across all populations in order to reduce the maternal and infant mortality rates in the state. We also are trying to ensure that all mothers, pregnant people, and infants receive the right care in the right place at the right time through perinatal regionalization efforts. At the state level, we've been working hard to try to align the work at the perinatal systems of care with our children's cabinet goals. We want to continue to strengthen the perinatal systems of care infrastructure in the state. We want to also maintain access to high quality perinatal care in the state, make sure that we're supporting our perinatal workforce and that we are offering high quality care throughout the state. As we look at this application, we want to make sure that you're aware that there is work happening in the state around perinatal systems of care through different both state and federal funding in our state currently. We do have funding in the state through the Maternal and Child Health Title V Block Grant Program with our maternal child health teams at the Maine CDC that works on our foundational work in the state around maternal child health. We have the Maternal Infant and Early Childhood Home Visiting Program, which you probably know it as Maine Families Home Visiting, that is also run out of the Maine CDC. We have our EMS for Children's program to the Department of Public Safety. And we have several programs, including WIC, MaineCare, Office of Child Family Services, and Early Intervention for Me at CDS that kind of provides foundational work at the perinatal systems of care. There's also some additional federal funding that's currently in the state to support perinatal systems of care work. Some of it's the Maine Mom program that runs at MaineCare to improve care for pregnant people with substance use disorder and their infants. The Maine CDC had a COVID disparities grant, which we used to fund a perinatal needs assessment recently, and also to set up basic life support and obstetrics training classes with our perinatal nurse outreach educators and EMS. The Maine CDC also has an early childhood comprehensive systems grant in the state maternal health innovation and data capacity program grant, which is funding a maternal health task force. The Maine Medical Association Center for Quality Improvement, which houses our perinatal quality collaborative, also has what's called a US CDC Erase Maternal Mortality funding opportunity to expand our maternal mortality review panel. And they have funding to fund the perinatal quality improvement collaborative for Maine, our PQC for Maine group, which you'll notice in the TMaH application is required to do work around Alliance for Innovation in Maternal Health, the AIM patient safety bundles. Maine Health also has a rural maternity and obstetrics management strategies grant where they're trying to improve rural health and access to maternity care in the state. And the Office of Child Family Services and Department of Education has a preschool development grant, which is working on some overlapping strategies. I say that because there has been a lot of work happening on the perinatal systems of care in the state, and we're looking at the TMaH application to really extend the work that's happening in the perinatal systems of care, continue to build foundation and infrastructure, but also as some of the funding, the federal funding ends that we have to try to use this potential funding in the future to continue some of the work that's happening in the state. I'm going to turn this over to our MaineCare team and Olivia Watson and Maggie Jensen, who is going to talk about the TMaH application. They're going to provide an overview. They'll have some slides, and then we ask people to hold questions till the end. So we'll have a question discussion period. So thanks very much for joining us today. We're excited to talk with you about the program and learn about where some of your priorities may lie around this particular application. So thank you very much.
Thanks so much, Amy. And I'll introduce myself. I'm Olivia Alford. I'm the Director of Delivery System Reform within the Office of MaineCare Services. It's so good to see all of you today. I'm joined with Maggie Jansen, who is the new and inaugural Maternal and Infant Health Coordinator for the Office of MaineCare Services, which is a great asset that the Maine legislature gave us a new position at MaineCare to help support this work. So another person that you'll be able to collaborate with on this initiative and many others going forward. I'm going to give an overview of this opportunity and talk a little bit about it in the context of what MaineCare has been thinking and doing and other efforts that are aligned. Maggie, you can pull up the slides whenever you'd like, and I'll just keep going to say that we really appreciate you taking the time to talk today. Whenever these opportunities come up, it's a great and this one in particular is a pretty comprehensive set of initiatives that align with the Biden-Harris administration's blueprint to address the maternal health crisis. And it offers a range of things for us to consider in Maine, whether we apply or are successful within this opportunity. So it's been a great catalyst for some conversations that I hope continue regardless of how this application process ends for Maine. So I'll walk through it today and we will have time at the end for discussion. And could you pull up the slides? I'm not seeing them yet, but.
Sorry, I thought they were up. There we go.
Oh, that's okay. So this is TMaH, we will call it that because it's a nice catchy acronym. The Transforming Maternal Health Model is exclusively focused on improving maternal health and newborn health for people that are enrolled in Medicaid and the Children's Health Insurance Program. Within MaineCare, we've recently expanded eligibility around pregnant people, including 12 months postpartum, and then also something that we've expanded eligibility under the Children's Health Insurance Program, CHIP, for pregnant people who have, so carrying children who might not otherwise be eligible for MaineCare because of their immigration status. So again, for MaineCare, this is a population we have, of course, always covered, but there's been some recent expansions in eligibility. The goal of this model is to reduce disparities in access and treatment. There's numerous mentions in the notice of both types of disparities in access and treatment, with a much of a focus on racial disparities, but also on rural disparities. And so we have to look at this from all angles and what that means for Maine and Maine people. This is a 10-year model, which for those of you who are familiar with federal models is quite a gift and quite a long time frame. So CMS has taken feedback from states that when they put forward models that are just 5 years, it's very hard for states to plan and implement, and for then CMS to see results from those models with that short of time frame. And then it's often that the federal government might cycle through another model right after that and another model. And so states have been pretty vocal that we need these models to be longer and we need implementation time so that we as a state can come together and figure out exactly how best to do this work. We need the money up front so we can make the changes so that this model is successful. And that is reflected here in this 10-year period with a 3-year pre-implementation period starting in January 2025 and a 7-year implementation period following. This will be highly competitive, we anticipate. It's only going to 15 states, and this is a high priority area for Medicaid programs across the country, and this administration at the federal level, and of course, many state, much state work going on. So we anticipate this being highly competitive. Next slide. This is a model focused and to be awarded to state Medicaid agencies specifically. We benefit from working with all of you, with our internal DHHS teams closely on this. So again, as Amy said, this is about really having an opportunity within Maine to build upon the work that's been going on, address any gaps, infuse additional funds, and do so with $17 million additional federal funding coming through this initiative. In addition to the 17 million, there's a number of requirements within this model, which expand MaineCare covered services or consider expansions to main care coverage services, which would mean additional federal money through the Medicaid program for some sustainability, which we'll talk about later on. For those of you on the call who may not read the whole notice of funding opportunity, I just want to call out that there is mention of a lot of you all in the notice. It's a pretty comprehensive, thoughtful process that the federal government has put forward about reaching out to your perinatal quality collaboratives, of course, your hospitals and health systems, FQHCs, rural health clinics, community-based organizations. They really, tribal health facilities, tribes, looking to see that we are doing a pretty comprehensive coordinated response for Maine. So you'll be hearing from us as we go through this process. As you're part of some of those groups, we'll be directly outreaching you for more information or for your ideas. Next slide. There are three main areas of focus, which just keep these in mind through the presentation: access to care, infrastructure and workforce capacity, quality improvement and safety, and whole person care delivery. The rest of the presentation will be a little bit more detailed, but keep in mind that those are the goals that we are working to speak to with this model. Next slide. All right, I'm going to spend some time on this slide because there are essentially 10 required elements of this model. And there are additional optional requirements, which we'll go over after. We are looking at these all closely, and it's important to always remember that the federal government is putting out these requirements, but the state has the opportunity to decide how they're going to meet these requirements and what that means for us based on where we are and where we want to go. So I'll just go through them. The first requirement is to increase access to certified midwifery workforce. This does not mean that the state Medicaid agency has to cover or reimburse directly for midwife services. We may want to, and that's certainly been a discussion in the past, but there's a lot of discussion to be had about covering additional services and what that looks like in terms of arrangements that need to exist in the community and between providers for some of these service expansions. So an example of what this could mean for Maine, again, could be coverage of these services under the Medicaid program, Maine Care program. It could mean thinking about e-consultation coverage so that midwives can consult with maternal and fetal medicine specialists and get paid for that. It could be patient education about midwifery services. It could be covering childbirth preparation classes, which are held by midwives through Medicaid. So there's different ways to think about these things, and that would be part of the process for us over the application period to figure out how we wanted to address this. The next one, increased access to birth centers, is also one that in Maine may look a little different than in other states. And we'd want to, if we pursue this, speak to this in a way that's competitive for our application, but also reflective of the fact that in Maine, we don't have a licensure for freestanding birth centers. However, there are some birth centers in Maine. And so most of what the notice of funding opportunity talks about is licensed and accredited birth centers. And so again, in Maine, where we're starting from, we need to think about how we want to move forward access to birth centers and whether this even applies to us. We are asking CMS for clarification because we don't have the licensed accredited birth centers in our state. But either way, we'll need to speak to how we intend to achieve similar objectives, which again here is to just make sure that there is access in different forms to maternity services. The last one again is another workforce access item. This does require Maine Care to cover and reimburse for doula services. So again, a little different here, actual Maine Care coverage for doula services. This is something that we're seeing through many states across the country. It is a process to determine how appropriately to incentivize and pay for doula services through a Medicaid program, whereas historically Medicaid has not paid for these services, and also to make sure that there's access and the actual workforce to deliver doula services to those communities that may especially benefit to help reduce disparities that are being experienced. So MaineCare would approach this as we do any other new service and have a rate setting process and lots of partner engagement around this. It would take us a lot of work, which we're open to work with all sorts of coalitions and dual service providers themselves to look like to see what this would look like for Maine. Number 4, improve data infrastructure. There's a lot of good ideas within this notice about better matching of data sets across social service programs and the Medicaid program to make sure people are finding their eligibility pathways for a whole set of services at the same time. There's information about making data available for the provider community to make whole person care more successful and efficient. And also technical assistance and expectations around just improved data workflows, again, on the provider side and on the state side. Something that will come into play with this model in the latter years is a value-based maternity services payment model. We'll talk a little bit about this later, but this is something that MaineCare has been interested in as a way to incentivize high quality services and reward high quality services, perinatal services. We'll talk a little bit about this because it's interesting that CMS will be helping us design this payment model with all of us in state. 6, implementation of the Alliance for Innovation of Maternal Health patient safety bundles. This work is underway within Maine, I believe, with hypertension and moving towards maternal mental health in the future. So again, capitalizing on that, supporting that work, wanting to know what we can do to make those implementation of those safety bundles the most effective in the real world for the providers actually implementing the safety bundles to achieve the outcomes they're intended to achieve. Similarly, with birthing-friendly hospital designation, many hospitals within Maine already have attested to or achieved birthing-friendly hospital designation, which is the first federal quality designation with a focus on maternal health for hospitals and health systems. CMS has been clear and is confirmed with this notice of funding opportunity that they will be increasing the requirements and expectations for maintaining a birthing-friendly hospital designation. And this funding is intended to help hospitals maintain that certification as the bar is raised. So we'll talk a little bit about that today, about what that could mean and what kind of support this model, this funding could give to hospitals to maintain that designation as the bar changes. Number 8, increase risk assessment, screening, referrals, and follow-up for behavioral health conditions, health-related social needs, and really whole person care. This will absolutely involve community-based organizations. This in Maine could look like a lot of things. There's already work underway, again, with tools like Find Help, with other states may not have systems implementing already. We have screening requirements, but there's lots in here about whether we standardize those, don't standardize those. How do we make sure that those screenings and follow-ups are happening and that there's a closed loop? Only 2 more, don't worry. Number 9, increase home monitoring of diabetes and hypertension. This likely would include expanded MaineCare coverage of home monitoring services. So MaineCare already covers telemonitoring for certain services through a home health lens, but it's pretty limited. This would likely extend MaineCare coverage, but also on the implementation side for the providers, making sure that they have the tools, equipment, all those things to workflows, technology to actually do effective home monitoring of diabetes and hypertension for maternal population. Lastly is the develop a health equity plan, which we'll talk about on the next slide as well. But it's really about developing accountability within both the state and the provider community for reducing health disparities. Specific goals, specific strategies with community development. So not a top-down design, but working together to develop realistic and actionable goals. And if you go to the next slide, we can show you a little bit more about the health equity lens for this whole initiative. It's not just about the health equity plan, but again, you're seeing repeat mentions of the importance of health-related social needs, data collection and screening, and the infrastructure needed to follow up and work with community organizations on those needs. All right, so we'll talk again. There's only a few more slides and then we'll discuss. There are a whole bunch of optional elements that Maine could decide to put forward in our application if we applied for this. That would include, again, the actual coverage of midwives, certified midwives and certified professional midwives, coverage of perinatal community health workers. I'm just calling a few out. Expanded oral health care requirements or infrastructure to support the increased need for oral health during a pregnancy and postpartum for the health of the baby and the mom. Regional partnerships, we've already expanded to 12 months postpartum, as have, I believe, the vast majority of states, 46 states, I think, have already done this. Group perinatal care and et cetera, additional telehealth, remote monitoring, mobile clinics. Okay. So we'll get to choose. And then for those of you interested in what the payment model might look like from a provider payment perspective, it's important to note here that MaineCare has in recent years done massive amounts of work to reform our rate setting system and to invest hundreds of millions into rates for different services, including physician and advanced practice register nurse services being updated to reflect the current year of Medicare. And then we're about to go live with our major hospital reform, which will be essentially putting almost $120 million into hospital services in the state. So MaineCare is really trying to increase the base level reimbursement across behavioral health, medical, dental, all these services. This is about changing the way we pay, and it's about providing infrastructure payments specific to maternal health. So in year 3 of the model, we will be required to start paying infrastructure payments to maternity providers. They will support care delivery transformation activities that could look like per member per month payments. It doesn't say specifically. Then there will be the addition of upside only performance incentive payments to start tracking, to start reflecting quality within a payment structure. The better quality, the higher those payments. Quality and cost are anticipated to be part of that performance incentive payment. And then in the latter years, the Medicaid program does need to work with CMS to implement the actual alternative payment model, which will change the way that we pay for these delivery, pre, post, and delivery services. As I mentioned, CMS is going to be designing this with us, so it doesn't say what that model will look like, which is a question mark. So we'll be part of that design process. Next slide. Quickly, not surprisingly, just wanted to make sure you all knew these are the initial performance measures that CMS notes will be part of performance incentive payments. They align with our Title V Maine CDC block grants, focus areas around some of the quality improvement work, and I think address some of the initiatives and efforts that we've seen, especially maternal depression screening, obstetrical complications, and obviously timeliness of care coming up from various efforts around the state. Next slide. So this is where we'll transition into some conversation. I wanted to put this slide here so that if you needed some brainstorming jump starts for how you think the funding could be used. Again, it's $17 million front loaded really in the first few, 8 million coming in the first 3 years, and the 9 million spread out over the latter 7 years. There's also technical assistance support, peer-to-peer learning, and one-on-one state technical assistance from the federal government throughout this process. And I mentioned that the Medicaid funding would be kind of additional to this, that comes with additional services. So before we go into reflections on where you think the model could best serve Maine, concerns, does anyone have any questions about the content that I covered?
And Olivia, I'll say a couple folks have asked about sharing the slides afterwards, and I don't think we have any issue, right, sharing the slides and recording this. So we'll plan to do that for all registrants.
Great. Well, yeah, so I know it's a lot of information. I think what I just want, we'll hand it over to Maggie to facilitate this conversation. And again, I think we know that we'll continue to learn things as we work through this with CMS. They're having additional webinars this week, and they will in the future as well. And so we welcome your feedback and then also your questions, and we can certainly pass some of those along. I'll hand it over to Maggie.
Thank you, Olivia. I've put up my my email there for anybody who would like to send me their questions or comments via email. Please feel free to do so. I'll be your direct contact going forward about TMaH. And then I will stop sharing now, and so we can all see each other, if that works for you, Olivia. Yep. I'll stop sharing and we can open it up to questions now and comments.
Maggie, I had a question. I'm not sure if this is something that's fleshed out yet, or if there's specifics to know, but wondering about the requirement to cover doula services, and if there's specifications in this plan for what exact services, because I know doulas do many wonderful different things. So if there's specifications around that, and then for what timeline, does it cover like a certain amount of time after birth or before birth, or are there any specifics around that?
A good question. I will take a look at the NOFO. I haven't seen specifics. Olivia, is anything coming to your mind that you saw?
No, I don't believe they were specific, and we've been working. And Emily, I don't know where you're from, if you might be already tracking this, but you know, a lot of states are doing this in different ways, that covering doula services, and so we've been tracking how other states are implementing doula services, and there's definitely a range. And I think with the timing, might be some opportunity for us to learn from those states that have already done this and how well their design worked for them to actually recruit doulas to accept the payments and provide the services, because you see states that do it with a bundled rate for just the whole pregnancy and postpartum. Some do separate for prenatal, separate for postpartum, separate for delivery, 15 minutes versus just a lump sum. So I believe from the reading of it that Maine would have our discretion to go through the process to design expectations, coverage, rates all by ourselves on this one.
Okay, great. Thank you.
Olivia, there's also a question in the Q&A. Do we anticipate wanting involvement from FQHCs? If so, related to which goals or activities?
Yes, we do. And there's specifically a mention of FQHCs that provide maternal services. And I know from other conversations that I've been having with the Maine Primary Care Association, we've talked about a shared goal around supporting FQHCs to provide maternity services. So I don't know, it doesn't say what that means exactly, but we certainly would like to see FQHCs increase access for maternity services across our state, and that they are explicitly mentioned here as a partner that should be involved.
Yes.
And Courtney, I don't know if you wanted to say anything if you came off mute. No, okay.
Can you hear me? No? Okay, sorry, it wasn't working. Yeah, I mean, I think FQHCs are such an important part of the our fabric of the state, and we want to make sure that they're part of the conversation, and where they aren't providing maternal or pregnancy services, we also see this as an opportunity to be able to continue to maybe expand capacity and support FQA2 growing in this area. So we want them to be part of the conversation. We want them, whether it's current supporting their work and integration into the broader fabric of pregnancy care, or also thinking about how can we expand in terms of what Olivia's mentioned in terms of increasing access and also equity. So I think that they'll be essential partners in this work.
I'm not seeing other questions. People can use the chat or the Q&A, or can just unmute and ask. Oh, here's another. Is there latitude for other screening efforts? For example, IPV, food insecurity. I'm not sure what IPV is.
Oh, go ahead, Maggie.
Yes, absolutely, there is. That's part of the HRSN, which is a requirement. And so we will want to be including that in the application if we go ahead with that, and that would be part of the model.
Sorry, the IPV, intimate partner violence.
Yeah.
Oh, sorry. Thank you. Not seeing other questions right now. I don't know, Maggie, if you want
Yeah, I
to.
can refer to, I don't really need to share the PowerPoint, but we did, unless Olivia thinks that's a good idea. We had some questions that we had come up with on our own. Let me just pull that up again. So one was, what are the most pressing perinatal quality improvement and safety issues in Maine to focus on, if there's anything beyond what's already been mentioned? So pregnancy hypertension, perinatal SUD, perinatal mood disorders. Is there anything that's been left out or not mentioned that you think we should be focusing on?
Hey, Maggie, great
Hi,
question.
Kelly.
I think the rural maternity unit closures that have happened around the state and assessing the impact of those and thwarting or minimizing numbers of future OB unit closures.
Okay, thank you.
And I just want to say, absolutely, Kelly, and huge reason for us to pursue this and think about how that can help the situation. And this has been part of, and I want to just reemphasize what I said before, CMS has framed this in a way to really think about rural health and rural communities. So it is, they are hoping to achieve greater equity and access and treatment outcomes for rural people through this. So that's something that in Maine we have to figure out what can the money do, what can the payment changes do to support that here.
Leslie and then Elizabeth.
Hi, I just wanted to ask for the group and for myself to understand the process for developing the grant application. What would be the meetings and what would be the expectations for various players? Because there are so many included in this. Might be helpful for the group to hear what you guys are thinking as you gather your thoughts.
Yeah, I can take that one. Well, the initial work that we need to do within the department is we've been socializing this for a period of time, getting initial input and feedback, reaching out to some critical partners about questions, concerns, capacity on their end, again, aligning it with current work, thinking about all of that. And then we need to make a process decision internally at the department, whether we can support the application going forward, capacity and priority and all these other reasons why, which we're, obviously very hopeful for. Then it's a sprint in August in Maine to get to an application due on September 20th. So I know that's going to be some requests coming out for meetings. And generally what the department does with this, this one doesn't require us to call out specific partners in a way that some other past grants have. So it may look more like individual outreach, not like a competitive process to determine who we list and don't list. That's not part of this application. Just making sure we're fully reflecting the work that the community is doing and that we want to leverage for this application. So there's so many different collaboratives and steering committees and such, luckily, around this area that will be utilizing all those existing touch points to keep you all informed and opportunity to contribute to this. And we will appreciate your attention to this during August and May if we are able to move forward.
Thanks, Livia. Elizabeth.
Hi, so my question feeds off of the question that Kelly Bowden asked, and it really is related to our rural level 1 maternal care centers. And the thing that is necessary for our rural level 1 maternal care centers to stay open is 4 very important things. You have to have a competent, well-trained nursing staff who is able to staff that unit 24 hours a day, 7 days a week. You have to have an obstetrical provider who can perform a cesarean section in a time that best aligns with maternal and infant needs. You have to have a pediatrician who can resuscitate a baby, or a pediatric provider, excuse me, who can resuscitate a baby, and that can come in many forms. It can be a family medicine doctor, it can be a nurse practitioner, it can be a pediatrician, and you have to have anesthesia to keep a level 1 maternal center open. And I completely agree that a lot of this support is really, really helpful for pregnant patients, but I don't hear anything in this proposal that helps us keep our level 1 maternal centers open. And so I would just like to know what in this proposal helps us keep those 4 resources in our rural critical access hospitals in this proposal.
Yeah, and I'll just say, I mean, I think this is the federal requirements, and this is not Maine's proposal, but I hear what you're saying. I think some areas that I could see Maine putting that in as how in this framework, I would say, is around the areas of patient safety, access to quality care. So specifically the patient safety and the birthing friendly hospital designation, which I know is not currently tied to the things you just mentioned. However, the federal government just released that rule that indicated that they're looking at level of care requirements. The ones I think are similar to what you were just mentioning for the different levels of maternity services, that they just released a rule to indicate that they have expectations for each level of care. So I think that the administration, the federal administration, would see that as being connected to the ability to deliver high quality care. And we would embed it within those two pieces. And we would speak to the fact that we're paying attention to the other federal signals that are coming down about level of care requirements.
Yes, but my question is, this model is throwing a lot of resources at a lot of different things. It's not throwing any resources into what I just asked about. And so I'm trying to understand why this model is going to help our rural units that are really trying to both maintain safety, but also to stay open.
Yeah, so we get to propose how we spend the $17 million, absolutely. So what I'm saying is we could put money towards workforce, hospital sustainability,
Capacity.
in those areas by saying that's part of how we will achieve the overall objectives of this model. That's what Maine, I think, has to do. We have to focus this on the things that we need to see in Maine. And there are other elements of this which we can achieve with limited resources. And then other ones that, will take more of the 17 million to achieve. So I guess that would be my short answer on that, is like, this is up for us to decide where to put the 17 million. And we're only going to pursue a model that makes sense for the challenges that Maine has.
Emily, and then Christina.
Yeah, I just wanted to mention that I think a lot of this sounds really good. I think that there's a huge need for the bolstering up of some of these community-based services. What I don't want to happen if we get this money is for us to end up kind of developing these different arms of our perinatal health care system. Like, I don't want us to focus on this, community-based or resources without also remembering that we have to be able to tie those into our like inpatient and outpatient systems, because as it stands right now, we have a lot of room to grow in fostering the relationships between our community services and our inpatient services. And so I think that if we continue to bolster and develop those community services, which I think is very necessary and needed and very valuable, we have to accompany it with building those relationships and making sure that we're all speaking the same language and working together. And I just think it's really important to recognize that we're nowhere near where we need to be right now. So any additional work has to include that in order to really be effective.
Thank you. That's a great point. Christina.
Thank you. I think I want to build on both Elizabeth and Emily's comments, but first I think it's essential that we do look at the deserts that we have created in OB and maternal health care. And are we at risk to making even more fragile decisions on eliminating these programs? And I think it's essential that we put resources into maintaining those very fragile programs. When you talk about health equity and access, the rural communities are now without access for maternal and women's health. And to Emily's point, is if you fracture and add more layers to this without building the infrastructure necessary to support it, as Elizabeth says, you can have all the community efforts you want out there. You still have to have a hospital, a surgeon, an anesthesia. You have to have all the support for something that goes wrong. And we need to make sure that when we're talking about what we do well, is that focus on what we do well and replicate that in these smaller communities. And that 17 million, my fear is if we are deeply committed to not only OB services and maternal health in these communities, it's an economic multiplier for an overall sustainable state, building healthy communities. And we need to invest more than 17 million. That is not going to manage the infrastructure needs to support these programs that are going to require significant subsidization. You're not having 700 births in small communities. So how do we look at the economic benefit of stretching these dollars, but also subsidization throughout this this grant period?
Yeah, thank you, Christina. And I just want to reiterate too that I think that the 17 million is the federal dollars. A lot of this, why I tried to mention some of the main care investments too, is like that's in another place to think about the money coming in, not just the main care investments that we've been making currently already, absent this proposal into hospitals and services, but also the additional main care investments that come with the model and the requirements on it, and the payment model, which we have a question about too, is that's additional to the 17 million. Is what does the payment model look like? What does the incentive payments look like? Those come out of additional dollars on top of this to try to get to, again, more sustainability. Not just, obviously not to even downplay all of the other work that's going on, that bringing in additional investment in the state to this point. But I think definitely hear you all loud and clear, and we agree. I think we just need, if we want to go after this funding, we need to do so in a way that's competitive, in a way that speaks truly to what Maine needs the money for and what we're planning to use it for, and absolutely be part of what's already going on, not intended to fracture it by any means, but just trying to leverage, I guess, would be the word we would try to achieve.
I think, Olivia, to that point, the work that's being done with the Department of Education, the Department of Labor, is a framework for what you're building on for economic sustainability for the state. If we don't start turning this around and turning our populations around, we are not going to have need for OB. And that is incredibly impactful for the sustainability of healthy and vibrant communities. I think that you can build a strong case for this, that these three different partnerships are impactful for sustainability. But I do think from another hospital that's announcing they're going to potentially eliminate OB services right down from MDI Hospital, is there's not too many more of these without looking at what the causation is, and it is highly trained, skilled individuals that are not coming into the pipeline, and we need to own some of that, but we also need to start working on that.
One of the questions that we had on our slides to prompt discussion was, are there some suggestions of things that we can put into this application? And sounds like, Christina, you have some ideas. And anybody else in terms of where you want us to start looking and start talking?
I have a thought, and I apologize that it is maybe not better thought out because it's kind of
That's
coming
okay.
to me right now, but
That's
I'm gonna
fine.
throw it out there for consideration. I think that it would be really, really valuable, like in my ideal world, there would be more nurse navigators in all places in the state that could help connect these community resources to our inpatient and outpatient systems, where their primary job is to make sure that patients are followed by the people that they need to be followed by, that they are connected to the services that they need to be connected to, and that they're connected in the way that best meets their needs. And so I think especially as we lift up some of these really wonderful community services, we need that connection to be built into our healthcare system. And I think it needs to come from the inpatient areas, only because there's less of them than there are community services. So it needs to come here, and then they need to be able to kind of have their hands in all the pots to find these patients and make sure that, yes, we're following them along. We're here, we have an understanding of what you're going through. So I don't have that very well thought out, but it's just kind of coming to me that it would be really great to have that type of infrastructure built in, which I think exists in a lot of places, but is certainly not across the board, and not standardized.
That was exactly the kind of idea I was looking for. So thank you, Emily, for that. Yeah, anything that is working where you're at that you'd like us to start looking at, to think about with this application if we go forward?
I like that
Rebecca,
idea. How
hi.
are you guys? Hello from Domain.
Hi.
Really exciting, great dialogue here, and great concerns and opportunities. One thing that I just like consideration is we have a level 2 NICU here, and and it's really needs to be sustainable for our communities, and being the second largest populated area here in Lewiston, and just any kind of subsidy or financial support for that type of service is super helpful to show that it's, I advocate in all my ways, but it needs to be, shown that it's financially sustainable for the organization as well. So just something to consider in our big global view of the state, how important our little level 2s are to offset the density in Portland and Bangor, because we often will try to send south and get turned away and have to go to Bangor. And so, which is, it's a wonderful option, but just a little bit further away for our families. And a lot of the families' reality, as you all know, and Lewiston is families often don't have cars, or ways to get to see their babies. So really focusing on keeping care local is important to me.
Thank you for that. Okay, Anne Marie.
Yeah, hi. I think this hasn't been said at this meeting, but it's sort of certainly not new stuff. Is sort of improving rural experience for residents and so on, and improving family practice, OB fellowship capacity and things like that. Again, in that idea of, developing competent people who can be at these smaller hospitals, who want to be there, that are incentivized to be in these places. Because that really is, I think, a recurrent thing, so that we home grow some, maybe through having a more robust, through a residency program rotation or stuff like, Liz would know more about capacity for that, the family practice residencies that do OB, and then again, those fellowship. And then also, we don't have a midwifery school in Maine. So those are all different ways that I think that this could be, the workforce could be improved. And I think a lot of that is in that Our Moms report that came out. And I know that Our Moms is coming, I think the follow through idea is that they're going to talk now to the hospitals that closed, to get some additional ideas. But anyway, those are my thoughts.
Thank you. We're so lucky to have the programming and the work that grants like Our Moms have been doing, and the work that Mary Ann Herrickle has been doing to lean on and to collect from with this, if we go forward with this application, because there's already been so much great work done that we can build on. Thank you. Anyone else? Emily.
Yeah, just one more thought. I think that we have a high need for substance use disorder champions, whether that be in hospitals or in clinics or wherever they are. I think we need a broad and connected network of individuals, but yeah, potentially RNs, potentially physicians or midwives, whoever they are, and in whatever capacity they're able to serve. I think we need a more connected network of people who are educated about how to best serve that patient and how to take care of them while we're transitioning them into a more formal care model.
Yes, absolutely. Yeah, Marie?
Yeah, sorry, I just thought about I don't know if anyone from Greater Portland Health is on or not, but continuing to support programs that are similar to what they've been doing with developing the prenatal care, providing prenatal care up until a certain point, and then partnering with OBs to do the final parts of the delivery. That's something that's being done through an HRSA grant, and it's really it's a very robust what they put together, and to be able to replicate that program in other places, I think is, I know there was interest in Lewiston to make it happen, but there were a couple of problems that got in the way of that, and to be able to expand those sort of programs, it's a model that they're actively working on, and I think we should be looking to see if we can learn from that.
Thank you, Maria. We have been talking with them, they are aware of this, and I agree with you. And I think, and part of what they're doing too, from an FQHC perspective, is they're also bringing in, I believe, community health workers, and it gets into the conversation about which there is a lot of conversation around community health workers that, and it's another set of existing resources that we're looking to make sure sustain in our communities and can connect, like they're already there. It's not like this is about further resources necessarily, but it is about training and making sure, like someone said, connecting to the services, the perinatal work, and to the right institutions, facilities, etc. for perinatal work.
Supporting them. I mean, there's a lot of interest in just being able to continue to support it.
This is Lisa. I'm just going to do a little time check because it's 12:56. I imagine a lot of folks have a 1 o'clock hard stop, but I think, Maggie, anything more you wanted to bring up or questions before we wrap up?
I don't. I will put my email in the chat. And if you think of anything after here and want to reach out to me, please do so. And I really am appreciative of all of your input today. Thank you.
Great. And Olivia, any other remarks before I turn to Amy to wrap us up?
I don't think so. We'll definitely keep you all posted, and I encourage you to reach out to Maggie on this because we will have to move quickly. So, and again, even if your comments aren't directly applicable to this conversation, or whether we do or don't proceed with this application or get funded, if we do, still Maggie is a great point person from a main care payer perspective. And then of course you have your other many other contacts within the state, like Mary Ann, for your broader maternal child health work.
Great. And I just want to thank everyone for joining us today, for reading through the, I think, 100+ page notice of funding announcement. So it's important for us to continue to build infrastructure in the state around supporting the perinatal systems of care work. So whether or not we move forward on this application or not, I would encourage you to continue to participate in the different projects that are happening with the Perinatal Quality Collaborative, with the Maternal Health Task Force, with the Maine CDC and others, so that we can continue to gather information and ideas from across the state on these issues. And we really just appreciate all of your thoughts around this. And feel free to reach out to Maggie. Her email is in the chat box about thoughts around this particular application as we try to just get a better understanding of what's needed to move it forward. So thanks very much. And we look forward to talking to all of you soon.
Great, and I'll just chime in behind that to close us up. And again, thank everybody for joining. I think we have a really unique environment here in Maine where we're able to have these discussions, where we can reach out and get 50+ of you on a call. So the ultimate decision, as Olivia said, will need to be with Maine DHHS, because it needs to be a Maine-based application, but we clearly cannot do it without all of you. So very much appreciate your partnerships and looking forward to continuing the discussion as we move forward. We will send out the slides and make the recording available to folks who want it, and we'll be in touch. Thanks so much. Bye-bye.